Hello?
Yes,
Hello?
sir. Yes, sir. It's
Yes,
audible.
sir, we can hear.
Yeah, I was speaking to Ravi Shankar sir. Hello? Hello? Hello?
Hello, sir. Yes, sir.
Yeah, there is some
Hello?
issue with my this thing. Okay, we'll start off the class. Sir, Trumanara. Hello?
Shirmali.
Okay, okay. Lakshman sir will not be joining. His brother-in-law is not well on that. So he's going to the hospital.
Oh, okay. Okay.
Okay, we'll start off with Raja.
Yes.
She'll be presenting a case of a thyroid nodule.
Good evening, respected teachers and my dear colleagues. Today I am going to present a case of neck swelling. A 29-year-old female homemaker resident of Tumkur came with complaints of swelling in the front of neck since 8 years and difficulty in swallowing since 1 month. Patient was apparently all right 8 years ago. Then she noticed swelling in the front of neck, which was insidious in onset, initially small in size and gradually increased to current size, and it was associated with discomfort in the neck. And there was history of loss of weight present, but there was no loss of appetite, and history of generalized weakness present. With these symptoms, patient was presented to the local clinician and evaluated and started on medications. Now, patient presented with complaints of difficulty in swallowing since 1 month, and there is no history of breathing difficulty or change in voice, and no history of any other swellings in the neck. Patient doesn't have any medical comorbidities, and there was no history of radiation to the neck. And family history, there was no history of similar swellings or any other malignancy in the family members. Medication history, she is on tablet carbimazole 10 mg twice daily. Patient consumes mixed diet and sleep and appetite are normal bowel and bladder habits, and she is not an alcoholic and smoker. And she attained menarche at the age of 13 years, and her menstrual cycles are regular with 28/4 cycles with normal flow. By summarizing the history, a 29-year-old woman came with complaints of swelling in the front of neck since 8 years, which was associated with discomfort in the neck and generalized weakness and loss of appetite, loss of weight, with difficulty in swallowing since 1 month.
Hello, Indraja.
Yes, sir.
You said there is no loss of appetite. Now suddenly you brought in loss of appetite.
No, sir, loss of weight, sir. Sorry, sir.
Okay. Now, other thing you have not said is, has there been any since this difficulty in swallowing has come up? Has there been any rapid increase in the size of the swelling?
No, sir. Sir, she gave history like she had difficulty in from past 1 month, sir, but the swelling is more prominent compared to the before.
No, but it
when
is
I asked,
important. No, it is
yes,
important for you to, even as a negative history, you
yes, sir.
should say that there is no sudden or rapid progression in size of the swelling. It's a
Okay,
very
sir.
important thing. It's a long-standing, swelling in the neck, which has now suddenly started showing symptoms, pressure symptoms.
Yes, sir.
So, for that to show pressure symptoms, has there been any sudden, rapidly progressing size of the swelling or sudden increase in the size of swelling? What does sudden increase in size sort of imply?
Sir, sudden increase may be
In this
because of
case
the
particularly.
What?
Sir, in malignancy, there may be sudden increase in
No,
size,
no.
sir,
There
and
will
in
not be
some
sudden increase in size in malignancy.
hemorrhage
Not in
into
it.
the
Hemorrhage.
hemorrhage. Yes, sir.
Hemorrhage into the either into cyst or into goiter swelling.
Yes, sir.
Okay.
Indraja,
Yes,
what do you
sir.
think is the diagnosis in this case? In this case, what do you think is the diagnosis?
Sir, this it presents, sir, like with this history, sir.
Of course, it with not
Yes,
with some other
With this
history.
history, yeah.
Yes,
See,
sir.
Indraja,
Yes,
please do
sir.
not make mistakes, stupid mistakes like this. See,
Yes, sir.
when they're asking a question, it is about this patient. They're not asking about some other patient.
Because
Yes, sir.
sir asked about what could be the cause of sudden increase or rapid increase in the size of the swelling. That's why I'm asking. You said malignancy, no? That's why I was asking what could be the diagnosis in this case.
Sir, long-standing goiter, sir. Long-standing goiter, it may convert it into malignancy also, sir.
No. Is it a case of routine goiter? You have said patient is on carbimazole or something,
Yes,
no?
sir. No,
For
no.
10 years.
Yeah, yes, sir. Yes, sir.
See,
So
Indraja,
you talk.
don't expose yourself.
Yes,
If
sir.
somebody is on carbimazole, what do you think is a problem?
Hyperthyroidism, sir. Yes, sir.
How many hyperthyroid or thyrotoxic nodules do you see which are malignant?
No, sir, rarely, sir. Only 1%
Then,
of the,
then,
yes,
then
sir.
why are you
Up
putting
to
your foot in the
3%.
mouth?
Yes,
Why
sir.
are you putting your foot
So
in the
that's
mouth?
why it is not malignancy if it is growing rapidly. Okay.
Yes,
Or
yes, sir.
like rapidly or suddenly, as sir said, it is hemorrhage. So even
Yes,
in
sir.
malignancy, it is very less percentage of toxic nodules which can go in for malignancy.
Yes, sir.
Sir, any other thing, sir? In
Students,
history.
any questions? What do you
Any
think of the history?
Indraja, is he
Yes,
still
sir.
on carbimazole or
Yes, sir.
it was phased out?
No, sir. Actually, she is continuously taking carbimazole. In between, they decrease the dose, and again, her thyroid levels are like fluctuating, sir. So sometimes they gave thrice daily, sometimes they gave twice daily. But she's taking continuously, sir, since 8 years.
Okay, fine.
Vinod?
Hello, sir. Hello, sir.
Hello. What are the side effects of carbimazole? Hello.
Hello, sir.
You're quite.
Sir,
He doesn't know.
no, sir. I
Okay.
don't.
Anyone else?
Sir,
If you
it
don't know, you
plastic
say don't
placenta, sir.
know.
Pavan,
Huh? Pavan.
Sir,
what are the drugs used for hyperthyroidism? And, for example, I want you to tell all the drugs in the management of hyperthyroidism, in the preparation of patients with, with the Graves or thyrotoxicosis for either surgery or radioiodine therapy.
yes,
What
sir.
are the drugs used?
Sir, carbimazole or methimazole, sir.
And then
And anything else?
Propyl thiouracil, sir.
Yes.
what is that? What is PTU?
Sir, it
If you-
inhibits the
If you have the
peripheral
choice, if you have the choice of giving propyl thiouracil or carbimazole, which will you give?
I will give propyl thiouracil.
Why?
Sir, it is rapidly acting, sir, and minimal side effects, sir.
And what else? What is its
And-
mechanism of action?
And it also inhibits the peripheral conversion of the T4 to T3, sir.
That is good. But what is the primary mode of action?
It inhibits that organification coupling.
Coupling of iodine, coupling of
Iodine.
iodine. So
Yes, sir.
it acts at the very root. And additionally, it has the effect of prevention of peripheral conversion of T4 to T3. So, which is why, unfortunately, it is not available in India. I don't know why.
But Pavan, side effects are also potentially more than this thing, especially liver damage. It can be
Okay,
fatal with propyl thiouracil long-term usage.
Okay, sir.
Sir, correct?
Correct.
Kala?
Yeah, but
Yeah.
only thing is India, it is not available for some reason. So we only
Correct.
give
India, it is not available.
carbimazole.
Pavan,
What are side effects of carbimazole?
Yes.
What do you monitor, man? Pavan, you are going for exams. When you given the patient
Patient is on
carbimazole,
patient for years together. No, no. What do you monitor? Sir is asking. No,
LFT, sir.
no, not LFT.
not PTU, man. Carbimazole. What are
Sir,
side effects?
agranulocytosis, sir. It will cause agranulocytosis.
What you will monitor?
So WBC count, sir. Total counts we will monitor, sir. CBC.
Correct. So
Yes.
total count
Yes.
and differential count. Not just total count, differential count also, because As you said very correctly, it causes agranulocytosis, which means the total white cell count may be normal, but lymphocyte may be high because there is agranulocytosis. So you have to get both total count and differential count.
Indraja,
Yes, sir.
any other drug history you will ask the patient and why?
Uh, uh, any iodine containing drugs, sir, like patient.
No.
Yes, sir.
With this history, no, patient is on carbimazole for such a long time. You will ask whether patient was taking any other medicines or
Any
not.
supplements like
Huh?
I'm
What
not
can
sure.
hyperthyroidism cause? How will you treat a case of hyperthyroidism? What all drugs you will give?
Sir, beta blockers, sir.
Why beta
Uh,
blockers?
To to reduce the effect of hormones, sir. Like if patient is going to thyrotoxicosis, to reduce
What
the
is
effect
the what is the reduced effect of hormones?
like a
You have to
patient
be very specific. Pawan,
Sir, arrhythmia, sir, it will
Yes, sir.
prevent, sir, palpitations.
arrhythmias.
Sir,
What does beta blocker cause, man? What does it do? It has
sir, bradycardia, sir.
it is a negative inotropic and chronotropic action. So it will reduce the heart rate, and it will also,
Heart rate.
I think mainly, and the advantage of beta blockers, especially propranolol, is also, it is also another drug that prevents peripheral conversion of T4 to T3.
Correct.
Vinod, why is conversion of T4 to T3 important, man?
Sir, T3 is the active form, sir, basically.
Both are active forms. T4 and T3, both are active forms. But you are right. What is that? So body will not have formed T4 if it was not an active form.
Yes.
So actually T3 is more active. No, that is the thing. If you look at this one, the binding of T4 and T3 to the peripheral cells from where it acts, T3 has more affinity to all the thyroxine binding sites.
Yes.
So that is why T3 is more active, because both are active, but T3 is more active.
Yes.
So if you prevent the conversion of T4 to T3, then you are reducing the toxic effects of the thyroxine or triiodothyronine.
So
What are
it
the
will
other drugs
reduce
that we use?
palpitations, tachycardia,
Yeah.
as well as heat intolerance also.
Yeah.
Yes,
correct.
sir. Please, sir.
What are the other drugs that you use?
Sir was asking something.
Indraja, patient has come to you, thyrotoxicosis. I am fed up of
Sir,
taking medications.
Lugol's iodine also.
That is no longer used now. Lugolcidine used to be used. If you say lugolcidine, I will ask you, what is lugolcidine? Tell me the composition. How does it act? Do you know?
No, sir.
Then why the hell did you?
Actually, you should be knowing all this in exams. They might ask you suddenly,
Ask
because
you.
you yourself might lead them into that, like now.
See, you should be clever when you answer in the exams. If you say lugolcidine, you should know everything about lugolcidine. Even though you are not supposed to say it, once you have said it, you should know about it. Otherwise, don't volunteer that information.
Okay.
Okay, what are the drugs that are they used? See, when patient is thyrotoxic, you want to get them ready for surgery or for radioiodine therapy. You need to control the toxicity. So we've said about
Yes, sir.
propylthiouracil, carbimazole. We have said about propranolol and beta blockers, especially propranolol. What else do you use? Patient has atrial fibrillation. What do you use?
What is the treatment for AF, Indraja? What did they give?
You know, you've seen the patients, they give infusion also. They give tablets also. What is that is when they use? Nikita?
Sorry.
Are you there, Nikita?
Yes, sir. Yes, sir.
What is the drug used to control atrial fibrillation?
I'm not sure, sir.
Come on, man. I thought it was very simple question. Praveen?
Indraja, Pawan, you people should be telling. Pawan?
Amiodarone, sir.
Yes.
Amiodarone.
Indraja, exam going. Did you ask about propranolol in this
Sorry.
case?
Sorry, sir.
No,
I-
don't be sorry.
Yes,
You
sir.
should be
Actually,
knowing
I
all this.
asked other than this drugs any.
The other thing that they use is corticosteroids. Again, corticosteroids has a salutary effect by reducing the peripheral conversion of T4 to T3. So all of these drugs can be given. I'm not saying they should be all given always. The usual standard drug is carbimazole or propylthiouracil if it is available, and then propranolol if the patient has thyroid toxic features with tachycardia, and atrial fibrillation, you add amiodarone. And when you are trying to prepare the patient for surgery, then you have to give steroids also to reduce the peripheral conversion of T4 to T3 and make the patient euthyroid. Why are we all talking about so much of conversion patient to euthyroid? Indraja?
Sir, patient will if we are not prepared properly, patient will go into thyrotox crisis, sir.
Thyroid storm. Okay, that is one.
Storm, yes,
What
sir.
else? More than that, somehow you can, I have not seen a thyroid storm. I don't think it happens these days. Anyway, you should know about it. But more than that, what are surgeons worried about? Pawan?
Like anesthetic drugs, sir.
No, not anesthetic drugs, man. Why should surgeon worry about anesthetic drugs? That anesthetists will worry about it. Pawan? I will give you a clue. Theodore Cocker got the Nobel Prize for this. Previously, before Theodore Cocker, a lot of patients used to die after thyroidectomy. So Theodore Cocker devised a method by which he got a Nobel Prize because he virtually reduced the mortality to very low numbers. So what did he actually do? Nikita?
Yes, sir.
Do you know the answer?
It was about blood supply.
Yes,
Blockage.
bleeding. See,
Bleeding.
a toxic gland is very vascular. So you will have significant, you can't control that bleeding. Patients will have catastrophic bleeding on the table. So you can't operate on a patient who is toxic. So anesthesia, all those things are all there. But as surgeons, you should be worried. You should have a patient who is euthyroid before you operate. Even then, the thyroid patients with Graves and all that, they will have very significant amount of blood supply. You have to be very careful. But you can't operate on a patient who is toxic because they will bleed catastrophically on the table. Okay.
Yes, sir.
Niranjan, what else?
Yes, sir.
Sorry.
Nothing else. I think
Okay.
we'll continue.
Continue.
Your diagnosis, Indraja, as of now? With
Yes,
the
sir.
history.
Yes, sir.
Give us your diagnosis.
Sir, it is a toxic goiter, sir. Long-standing toxic goiter.
Toxic goiter. What is the difference between toxic
So-
goiter and is there any difference between toxic nodule and a toxic nodular goiter? What is the difference?
Sir, toxic nodule means only one nodule in the unpalpable gland, sir. Goiter
is
means
solitary
enlarged
nodule.
thyroid, sir.
That is solitary
Yes,
nodule.
sir.
Definition you're
Toxic,
telling.
solitary. Yes, sir. Yes.
So tell us what is the difference between toxic nodule and a toxic nodular goiter? Anyone else? Pawan?
Sir, Sir, toxic nodule is only one nodule in the gland, sir. Only one palpable nodule in the gland.
Which is?
Hello, sir.
Which is what?
which is functioning,
Hyper functioning.
hyper functioning, yes.
Which is hyper functioning. Okay.
Hyper functioning, yes.
Yes,
Sir.
in toxic nodular goiter. Yeah, in toxic nodular goiter.
There are multiple nodules that
Which can hyperfunction.
Or
Okay.
the entire gland may be hyperfunctioning.
Or entire the gland might be hyperfunctioning. So is there any difference? Is there any difference in management? Why do you want to know
Hello?
that?
Indraja.
Hello,
Is there
sir.
any difference in management? Hello? Hello?
Sir, in toxic nodule, we can if yes, yes, sir, yes, sir.
What is
Sir, if it is toxic
sir?
nodular goiter, we have to do the total thyroidectomy, sir.
Okay, or subtotal thyroidectomy.
Hello, sir.
Correct, correct. Talk.
Tell me, continue.
Hello, sir.
We are
Hello?
hearing you, ma. Come on.
Sir, if it is toxic nodular goiter, we have to do total thyroidectomy, sir. If it is toxic nodule, we can do hemithyroidectomy.
Not total
No
thyroidectomy.
surgery,
ma.
even in toxic nodular goiter or entire, if it is solitary toxic nodule, still the first line of treatment is radioiodine. If you want to do surgery, then it's okay. What you're telling is correct. It is either as Swar was telling, if it is only the one of the nodule is hyperfunctioning and rest of the gland is normal, you can probably get away with hemithyroidectomy. Correct, sir?
Yeah. What happens is when there is toxic nodule, Indraja, please understand the nodule is so dominant, the rest of the thyroid will be suppressed. So there will be no uptake of iodine, no functioning of the rest of the gland. So once you remove that gland, then because of the autonomy of the solitary nodule or the toxic nodule, the TSH, TRH axis would have been suppressed. Now that you remove the nodule, that axis is re-established, and then the gland will become, it will start functioning normally. So you are well within your rights to do a hemithyroidectomy if indicated. As otherwise, Niranjan said, the current standard treatment is radioiodine therapy. Understood? Everybody understood?
I think
Hello?
Indraja left something. She logged out. Indraja is logged out. Hello?
I think she's probably
Yes, sir. She has logged out.
She'll come back, I think.
And one more thing is about the amount of dosage of radioiodine. They say generally in toxic nodule, the dosage might be little higher when compared to in Graves' disease or in entire thyroid toxic nodular goiter.
Indraja, have you joined back? So,
Abdul, just find out what happened.
Okay, sir. I'll just call her up.
Sanya, are you there? Hello?
Sir. Hello.
Sanya, good
Yes,
evening.
sir. Yes, sir. I'm here. Good evening, sir.
You should talk.
Yes, sir. Yes, sir. I will.
Tell us what do you think?
You can also ask questions.
Yes, sir. Yes.
You are
I will get it.
you are assistant professor, you are registrar of surgery. You should ask questions.
Yes,
You should not
sir, I
allow
get
us
it.
to talk. We should not allow be talk. You should be
Yes,
talking.
sir. Yes, sir. I will get it.
See, it's first of all, online, nobody is seeing
Yes,
you.
Yes.
Tanya,
Yes, sir. Yes, sir.
nobody is seeing you, so you can be. You don't have to be, aware or what you call that. You don't have to be
Yes.
worried about anything. Just talk, and then
Yes, sir. Yes.
you will become bold and. You're from Bangalore Medical College. You shouldn't be.
Yes, sir.
You shouldn't be worried
Yes,
at
yes,
all.
sir. Yes, sir. Right.
Abdul, you were asking some question, no? That time we had interrupted.
No, I
What was it?
just wanted to ask Indraja, sir, which is safer in pregnancy? Which drug is safer in pregnancy?
Yes, yes.
Among the
Pawan can
hyperthyroid
answer by the time.
medicines.
Propyl thyroid also, sir.
Propylthyroxine is what?
Why?
Safer in pregnancy, sir.
No.
It does not cross placenta, sir.
Propylthyroxine, correct.
Yeah, yeah.
Carbimazole
Correct. Carbimazole is not.
is known to cause congenital defects. Yeah, correct.
Yes.
What has happened to her? She has not yet
I
joined
called
back.
her up. She said she's joining. I don't know. Again, I'll call her up. So,
What is the problem?
network issue, it seems. I'll just call her up again.
Pawan, you have seen the case? Pawan,
He's
Sir.
also not.
Pawan, you have
Yes,
seen the case?
Yes, sir.
Sir, till she comes, let Pawan
Yeah,
present. Pawan, present the examination findings.
Examination findings, man. Come on, start. What is your history diagnosis, man, Pavan?
Sir, my history diagnosis is a solitary nodule of thyroid with hyperthyroid features, sir.
See, you can't say solitary nodule of the thyroid without examining the patient, correct?
Yes, sir.
So how can you say solitary nodule?
Sir, benign thyroid nodule, sir.
See, you should say this one, patient, I think the diagnosis in this case should be long-standing goiter with hyperthyroid features on treatment. That is all you can say at the moment.
Okay, sir.
I don't know whether the patient on history at the moment, there are no features suggestive of hyperthyroidism. So you can say the patient is euthyroid on history.
Okay, sir.
So long-standing goiter with recent increase in size. So well-controlled hyperthyroid features.
Okay, sir.
That is all you can say.
Sir, Nikita is asking, is there any definition for long standing?
I don't think there is any definition as such. I don't know whether there is. I will check that, Nikita.
I don't know. I also don't know.
I saw the question.
I also don't know. Usually, probably anything beyond 2 to 3 years, I think we can call it as long standing. I don't know. I don't think there is any clear cut definition for long standing.
No definition. We'll ask Sania. Sania, you have just finished, no? Is there any definition, for long standing?
No, sir. No, I am not aware of any duration to call
Okay,
it long
right.
standing.
Nikita,
Yes, sir.
don't ask difficult questions.
Sir, I was just confused. I thought maybe 10 years. As it was 8 years, can we call it long standing or not? That's what, sir.
I'm joking.
Okay.
You can ask any question you
There
want.
is no clear cut definition as I'm aware also. I think
Yes.
it's just arbitrary.
Okay.
Pavan,
It's just having existed for a long time. That is what is called.
Niranjan, what would you give as is one clinical diagnosis on history?
Same, sir. Same what you mentioned.
Okay.
Long-standing, probably long-standing thyroid nodule with the toxic symptoms, probably.
Yeah, I think that's all. Indraja, are you back?
Yes, sir. She's there.
Indraja?
Yes, sir. Sorry, sir.
Talk.
Yes, can I continue?
Okay. Please continue. We are waiting for
Yes,
you.
sir. Sorry, sir.
Pawan escaped because you logged in.
We'll still make
I
Pawan present.
also tried to log in, sir, from my system, sir. I'm trying to present, sir.
Okay, present. Okay, anyway, now
Yes,
I think Indraja is back. Indraja.
Yes, sir. Yes. Patient was examined in sitting position after taking verbal consent in well-lit room with adequate privacy. Patient was conscious oriented with Karnofsky performance score 90 and ECOG score 1, and she's moderately built and nourished with BMI 21.2. There was no pallor, icterus, cyanosis, clubbing, pedal edema, and generalized lymphadenopathy, and there were no eye signs and tremors. All her vitals were normal and pulse rate is 84 per minute measured in right radial artery, which is regular and normal volume, and blood pressure is 130 by 80 mm of Hg, measured in right brachial artery in supine position, and the respiratory rate is 18 cycles per minute. On local examination,
Indraja,
sir,
one
this is
second.
the
One
swelling,
sec.
sir.
Indraja, 1 second. What is the difference with respect to eye signs between toxic nodular goiter and Graves' disease?
Yes, sir. Yes, sir.
What is the difference with respect to
Hello,
eye
sir.
signs? What is the difference with respect to eye
Yes, sir.
signs? Eye signs in toxic nodule or toxic nodular goiter and Graves' disease.
Indraja, are you listening? Again, she's probably, she has.
Indraja, you're there or not there?
I think what is happening is her bandwidth is not
Pawan?
good enough. Abdul,
Pawan?
Sir.
Abdul,
Yes, sir.
Pawan, is your
You can
bandwidth
answer.
good? Is your
Yes, sir.
bandwidth good? Hello?
Sir, I am
Yes.
sharing her PPT, sir.
So what you do is you present, you share the, I think her bandwidth is not good enough. So what you do is let her log in like that.
Yes, sir.
You share the presentation.
Yes, sir. I am sharing that only. Sir.
Because if your bandwidth is not good, you cannot have both audio and video. So whenever she's putting up the video, her this one is going off.
Pawan, you can share, and in the meantime, you can answer the question also.
Yes, sir. Sharing, sir. Sharing, sir.
No, did you hear my question?
Please answer that question,
Sir,
Pawan.
sir, some echo is coming.
Pawan, can you share the PPT, please?
Indraja, now can you hear us?
Yes, sir.
Niranjan's, Dr. Niranjan's question is,
Yes, sir.
what is the difference in eye signs between a
Yes.
Graves' disease and a toxic nodule?
Sir, in Graves' disease, like proptosis will be there, sir.
No.
Yes, sir.
Whenever there is eye signs, there will be proptosis and all those. What is
Yes.
the difference? Will eye signs be there in toxic nodular goiter?
No, not always, sir.
Toxic nodular goiter, invariably it will not be there.
Yes,
Okay,
sir.
it will be present
Yes,
in
sir.
Graves' disease.
Graves' disease, yes, sir.
Who is sharing the presentation now?
Pawan.
Sir, I am sharing, sir. Is the screen is visible, sir?
Yeah, visible. Yeah. Now go to the current slide.
Make it full screen.
Sir, it's full screen only, sir. Now, sir?
No, it is coming as...
Make it as a, slide, this one, no?
Sir,
yeah.
Click on that window. Yeah, click that.
Now it came,
It
sir.
is not happening.
No.
But in my system, it is in full screen only.
Okay, anyway.
Okay, continue then.
Yes.
Next.
Come to the local examination.
Yes, sir.
Indraja,
Local
present.
examination.
Here the video is there, sir. Can I play it?
After that, Pawan.
It is not moving, Pawan. This also is... Yeah, play that. Indraja, you can continue. Local examination,
Yes,
inspection.
Yes, sir.
Why is it like this? Why is it rotated?
Now, yeah. Okay, Indraja, come on.
Yes, sir.
Start.
A single swelling of size 6 cross 5 centimeters present in the right thyroid region and isthmus, and the surface appears to be smooth, skin over the swelling normal, and the swelling was moving with deglutition and lower border is visible. Trachea appears to be deviated to the left side, and it extended horizontally from 1 centimeter left of the midline up to the and the lateral border is just behind the anterior border of the sternocleidomastoid, and vertically it extended 5 centimeters from suprasternal notch below to the thyroid cartilage above, and there were no visible scars or sinuses over the swelling and no other visible swellings in the neck. On palpation, all
See,
the
what sinuses are you expecting?
See, that is how you land up in trouble, Indraja. Unnecessarily, you will you will get questions there if you tell like that. You can
Yes,
just say skin is normal.
Okay.
Rest of
Visible
the
scar is
neck
okay.
skin is
Visible
normal.
scar, you can say visible scar because it
Okay.
patient previously operated or whatever. You would have
Yes.
told it in the history, but maybe you can still say there are no visible scars. But sinuses unnecessarily we are not giving differential diagnosis of thyroid, this one, not tuberculosis.
Yes, okay.
So
On palpation, yes, sir.
okay. So don't mention that.
Yes, sir. Okay. On palpation,
Go back.
Yes, sir.
Okay.
Yes.
Continue.
Yes, sir. On palpation, all the inspectory findings were confirmed. A well-defined swelling of size 6 × 5 centimeters involving the right thyroid lobe and isthmus, and the lower border is palpable with smooth surface, firm in consistency. Trachea deviated to the left side, and there were no other palpable swellings in the neck. On percussion, resonant over the manubrium sternae, and auscultation, there were no audible brew here.
Bruit.
Yes, brew.
Left lobe of thyroid, you needn't say anything about left lobe of thyroid.
Sir, I couldn't palpate, sir, left lobe.
And who is going to say that?
Sorry.
You have to mention, no?
Yes, sir. Yes, sir. And systemic examination, all other systemic examination was normal. No abnormality was detected.
See, in this case,
Yes,
you are
sir.
talking about thyroid toxicosis.
Yes, sir.
Specifically, you should mention the heart rate, the CVS findings, that
Yes,
there are
sir.
no murmurs, there are no, atrial fibrillation. All these things you're supposed to mention, ma, because
Yes,
you're
sir.
talking about a patient with long-standing thyrotoxic nodule.
Yes, sir.
You have to mention that. I think it is, imperative that you mention that. You
Okay,
can't,
sir.
like not other thyroid nodules, you can't say systemic examination is otherwise normal. It won't
Okay.
work.
Okay, sir. Can I summarize, sir?
No, specifically, you also have to say clinically there are no signs of thyrotoxicosis at the
Yes.
present time, because the patient has been diagnosed and as you said yourself, been getting carbimazole.
Yes, sir.
So you have to say there are no clinical signs suggestive of thyrotoxicosis in the
Okay, sir.
form of tachycardia, tremors, excessive sweaty palms,
Yes,
eye
sir.
signs, and then
Okay.
tachycardia, and then atrial fibrillation, all these things,
Yes.
pretibial myxedema, all of these things have to be, what do you call them? Apart from positive findings in the history,
Yes, sir.
significant negative findings also has to be mentioned. Niranjan? Hello?
Yes, sir. I agree, sir.
Yes. Anybody
Yes.
else has any question in the clinical findings?
Sania Abdul.
Abdul, do you agree with the clinical findings?
Yes, sir.
Abdul? Where is he gone now? Abdul, are you there? He's gone somewhere.
Sania.
Yes, sir. Yes, sir.
Anything in terms of the clinical findings, do you agree or disagree? Did you want any more information?
No, sir. Nothing else to add, sir.
Okay.
Okay.
Yes.
Summarize.
Yes, sir. Summarizing the history, a 29-year-old woman came with complaints of swelling in the front of neck since 8 years, which was associated with discomfort, generalized weakness, and loss of weight. and with difficulty in swallowing from past 1 month. On examination, a well-defined swelling of size 6 cross 5 centimeters involving the right thyroid lobe and isthmus, moving with the deglutition with smooth surface, foam in consistency with deviation of trachea to the left.
See, movement with deglutition need not be mentioned as in the summarizing, because
Okay.
you make a diagnosis of a thyroid nodule, it has to move with deglutition. So there is no need to. It is when you are examining, of course, but not
You
now.
can directly say that it is a thyroid nodule.
Okay, sir.
You
So
are
what's
to
your
directly
clinical
say it is a
diagnosis?
thyroid nodule involving the right lobe of thyroid.
Yes, sir.
Toxic solitary nodule, right lobe.
Right, and isthmus of thyroid, sir, mostly benign.
So do you think all this is whole thing is a big one nodule?
Yes, sir.
Involving the right lobe and the isthmus.
Yes, sir.
Niranjan, do you agree? I have not seen the patient.
Nanu nodilla, I have not seen. Probably it is Abdul.
Is it, sir? I think it is multinodular, sir.
So that means there are
Multinodular.
Intra-op usually.
no, but
Huh?
on clinical we are not talking about intraoperatively. Clinically,
Clinical examination.
do you think it's a
Clinically, it looks
solitary
single
nodule?
only, sir, on examining. But intra-op, I think it was multinodular.
No, sir, intra-op also it's not multinodal.
Whose patient was this?
Sir,
Subhas,
Subhas, sir,
sir.
patient, sir.
Operated.
Yes, sir.
Okay, who was there in surgery?
I was there, sir.
So this is a single nodule.
Yes, sir. Actually, I have the picture in my
Okay.
PPT. It is there, sir.
Okay, right.
It is not
Okay,
there.
right.
Yes,
Let us go to that later. Now, Niranjan, questions now.
Sir. Sir. How do you evaluate? Indraja.
Sir, first I will do the thyroid profile, sir. To look whether it is normal, whether patient is in euthyroid or hypo or hyperthyroid status.
Okay, carry on. We won't
sir.
stop you.
Yes, sir.
Continue.
If patient is having low TSH, then we have to proceed with the radioactive iodine scan, sir, to look for the nodule status, whether it is hyperfunctioning.
No, before that, before
radioactive iodine, what do you do?
Ultrasound, sir, ultrasound of the neck.
Okay.
And
what will ultrasound tell you?
Ultrasound of the neck.
Ultrasound, yes, sir.
Yes,
Ultrasound
continue.
of the neck, whether it will show the size and whether it is cystic or solid.
Okay.
Whether hypo or hyperechoic or isoechoic, margins, whether it is irregular margins or well-defined margins, and calcifications, any calcifications are there or not. Yes.
And what else?
And vascularity of the glands.
Correct. So what do you expect the vascularity of this to be?
Increased vascularity, sir. High vascularity in this case.
Increased vascularity of the nodule. Yes.
Yes.
As opposed to the rest of the gland.
Yes.
You need not have to do radioactive iodine for assessing whether that is a nodule is hyperfunctioning or the gland is hyperfunctioning. What is the other alternative apart from that? What thyroid scan you can do? Usually preoperatively they don't do radioactive iodine, they do technetium 99.
Technetium, yes, sir.
Thyroid scan to assess. Yes. Yeah. So radio iodine is for therapeutic purpose.
Okay, sir.
Indraja,
yes,
I've told you so many times. I think Niranjan has told you so many times. Basically, radio iodine scan 123 is not available in India. Okay.
Yes, sir. Yes,
so
sir.
that is the short acting this one, that is for diagnostic purposes. Iodine 131 is for therapeutic purposes. So you should not say radioactive iodine. You should say radio. It's one technetium 99
Yes.
Thyroid scan. You said
thyroid
scan.
Scintigraphy,
Probably
sir, yes.
technetium
thyroid
99.
scintigraphy.
Yes,
so
sir.
iodine scan is not. you are right. If you had it, we could have done it, but we don't have that isotope. So we
I-123 is generally not available.
not available. So we are going to do technetium-99 M scan.
Yes, sir.
Okay, what will it show you?
Okay.
Sir,
Technetium,
whether hot nodule or cold nodule, sir?
what do you expect in this patient?
Like hot nodule, sir.
What is the definition of a hot nodule as opposed to a cold nodule as opposed
Increased uptake increased uptake by the nodule, sir, compared to the rest of the gland.
I will call that warm nodule.
So, increased uptake suppressing the rest of the gland.
So uptake, majority of the uptake is
Yeah.
in the nodule.
Uh,
The rest of the gland, the uptake is very minimal. So
Yes.
then that becomes a hot nodule.
Hot.
If the uptake is higher in this nodule, but rest of the gland also has uptake, then it becomes a warm nodule.
Yes, sir.
If there is no or limited uptake in the nodule as opposed to the rest of the gland, then it is called a cold nodule.
Yes.
Okay. What does cold nodule signify?
Sir, cold nodule, chances of malignancy is more, sir, around 20%.
No, actually, cold nodule, you have to be wary that it is likely to be malignant, but even 30 to 40% of benign nodules are also cold. So it doesn't always necessarily mean cold nodule is malignant, but
Yes, sir.
hot nodules are usually not malignant.
Not,
So that
yes.
is what you need to be this one.
Okay.
What is, as Niranjan told you, can you remember what is the percentage of hot nodules which are malignant?
So 1%, sir.
Not 1%.
It's
Bit more
around
than
3%. It
3%.
varies between, it can go up to 10%, but usually average it is around 3%.
3%,
Yes.
correct. Up to 10%, but 3% is more nearer the figure.
Yes.
So that is why you should never make a diagnosis of malignancy in patients who have hot nodule. Of course,
Yes.
there are rare variations, but in the exams, you should not say that. Okay.
Yes, sir. Yes,
Okay.
sir.
In this case, how is
Yes,
it
sir.
relevant, that thyroid scan? How is it useful? If you do thyroid scan, have you done in this case thyroid scan?
No, sir, not done.
What will
Any
it show
reason?
you?
Sir, I spoke, actually, a patient was advised with isotope scan by their clinician and came here. And sir saw them. Sir initially advised scan, but later sir proceeded with the surgery, sir. When I asked sir, sir said, like, as a patient from village background, and they have to be in regular follow-up if we have done the scan. And they are not affordable also. So sir said, like, then sir went with the surgery.
No. I'm not
Yes,
talking about radioiodine, pa.
yes, sir.
I'm not talking about radioiodine. I'm talking about thyroid scan pre-op.
Yes, sir. Like, I spoke to sir. Sir told me this reason, sir. Pre-operator.
No, that reason is
Then,
correct
sir,
for radioiodine, not going ahead with radioiodine
Yes, sir.
treatment. One of the reasons. There is
Yes.
other reason why you have to do surgery in this case that we will ask you later. I'm asking you
Yes, sir.
about pre-operative thyroid scan. Technetium 99. You said technetium 99 I will do. If the
Yes, sir.
technetium 99 says that that only that gland, that nodule is hyperfunctioning, and if the technetium
Yes.
99 says entire gland is hyperfunctioning along with that only one nodule which is more hyperfunctioning, what could be the difference? How will it affect you in management?
Sir, if it is only nodule is functioning, we can do the hemithyroidectomy, sir.
Correct.
If it is entire gland is hyperfunctioning, then we have to do total thyroidectomy, sir.
See, this is a benign condition.
Yes, sir.
So I know the definitions of near total and all those subtotal and all are very blurred. But
Yes.
here you are supposed to leave a sliver of normal thyroid tissue or a bit of thyroid tissue because it's not malignancy.
Yes,
So
sir.
you do a near total thyroidectomy. You don't usually say total thyroidectomy. Total thyroidectomy is a procedure of choice for malignancies.
Yes, sir.
So probably in this case, if only that gland was hyperfunctioning, that the right lobe of the nodule, whatever right lobe nodule was hyperfunctioning, you probably could have done only right hemithyroidectomy if left lobe
Yes,
was
sir.
normal.
Yes, sir.
Okay. So what
So
other?
that is where it helps. That is one thing. Second, it helps in calculating the dosage of radioiodine. If you're planning still right now, the current guidelines, as per the current guidelines, the current recommendation is radioiodine is the first line of treatment
Yes.
for thyroid nodules, even solitary thyroid nodule and solitary nodular goiter.
Okay,
Sir
sir.
was asking something, sir. Sir,
No. I think that's what you basically got the answer. So now you have done ultrasound, you have done radioisotope scan, and you said the thyroid function tests were patient is euthyroid.
Yes, sir.
So now if the patient has come to you, what
Yes,
will
sir.
you offer as a treatment?
Sir,
Why did you choose to do surgery?
because it is a long standing, sir.
Ah.
Patient is on like
no,
antithyroid
Indraja,
drug.
we
Yes.
just now told you, long standing, it is nothing to do with malignancy in this case.
Yes, sir. But patient is
So
on
long standing doesn't
antithyroid.
matter.
Yes, sir. Antithyroid drugs,
Yes,
sir.
so you have to do some therapy. Continue.
Yes, sir.
So
As she's taking antithyroid drugs since long time, and the goiter nodule is increasing in size.
Okay.
So I want to go for the surgery. I would like to go for the surgery, sir.
Why not radioiodine?
We can give radioiodine also, sir. Either radioiodine or surgery. We can.
No. If
Yes,
I
sir.
am asking you very clearly, patient
Yes,
has
sir.
come to you, you are the surgeon. What
Yes,
will
sir.
you offer her? And why? Why did Dr. Subhash consider surgery? You should know the answer for that also. Is he wrong or is he right?
Sir is right, sir. If we are offering radioactive iodine, patient should be on regular follow-up, sir.
Not just that. Yeah, that is one of the things.
Yes,
But
sir.
regular
that is-
follow-up, how long you expect them to be on regular follow-up? What is the difference between radioiodine therapy in Graves' disease and radioiodine therapy in a toxic nodule? What you said was correct, but what I'm asking you specifically,
Yes.
why do they have to be on regular follow-up?
So patient may go into hypothyroidism also, sir, after giving the therapy.
Going to?
Hypothyroid, sir.
Yes.
Mm.
what is the failure
Go
rate
ahead.
of radioiodine therapy?
Sir, 50% relapse.
50% is a bit too much.
Yes.
30%. It is around
20 to
30%.
Yes, sir. Okay.
Sania? Hi, Sania, what is the failure rate of radioiodine therapy, ma? Not sure. Abdul?
I'll find out.
Abdul?
Not sure, sir.
Niranjan has just told you, man.
30%,
20
sir,
to
said,
30.
but I am not sure about
It
the
is around 30%
No, I was
a
just
toxic
asking that question
nodule.
because I wanted to know whether you are all attentive or not. He just told
exact
you the
percentage. I don't know, sir. That's
In Nikita has a question. I think. What is that, Nikita?
Sir, does examiner expect us to ask about the kids, sir? Because she was on carbimazole and reproductive age group, and she had 2 kids during the period of 8 years, sir.
Oh, she had kids during it. Then it is a relevant question.
Yes, sir.
Did she have kids during this period?
Yes, sir.
Yes, sir.
2 years back and 1.5 year back.
Okay.
So they did
Then
not
it's a
convert to.
relevant question.
it is
Okay, sir.
relevant. We should ask.
What
Okay,
was
sir.
given during the pregnancy and all those things? A relevant question.
See the
Yes, Indraja.
Indraja, you have said
Sir.
radioiodine this one, but surgery, how do
Yes.
you justify the that Dr. Subhash has decided to go for surgery, not radioiodine therapy. So one is the follow-up, I agree. Second
Yes,
thing is,
Follow-up. If the patient was coming for follow-up regularly, if he was a urban patient, like from a major center, what
she is
would you
young
have
age,
done then?
sir. Young age.
Okay. So,
engage is not any contraindication for radioiodine.
I'm not sure, sir.
What has happened recently?
Difficulty in swallowing, sir. She's
Pressure
developing
symptoms.
pressure symptoms. Yes,
Pressure
sir.
symptoms.
yeah, she
Yes.
has the pressure symptoms. So even if you give radioiodine, the pressure
Yes, sir.
symptoms might not go away.
Okay.
Okay, so you are correct
sir.
in doing surgery, but you have to justify the whatever you answer in the exams.
Yes, sir.
So
Okay.
patient has pressure symptoms. Okay,
Yes, sir.
what surgery you will offer in this case?
Sir, hemithyroidectomy, sir.
Huh?
Hemithyroidectomy, sir.
Okay, what was
Yes.
done?
Sir, total
Right
thyroidectomy was done, sir.
hemithyroidectomy.
No, sir.
Any
surgery,
reason for that?
Sir, like that's what sir has done. Any isotope scan, sir.
So,
But sir, when I asked sir said like they have to come for repeated follow-up. They're not that much affordable. So that's why I did a total thyroidectomy. That's what sir told me, sir. Yes.
No, that you can't
what would
answer
you
like
do?
that in the exam. You have to.
So what would you do?
Sir, I will do hemithyroidectomy, sir. Right hemithyroidectomy.
What will happen to thyroid functions after that?
Uh, it like thyroid levels will be normal, sir. After the surgery, we have to be follow up the patient.
See, this is why
Yes, sir.
Niranjan kept on telling you radioisotope scan, technetium 99M scan is critical in
Yes,
this
sir.
patient before you plan any surgery.
Yes, sir.
Because if even though clinically there is no palpable nodule on the on the this one clinically or on ultrasound for that matter, if on technetium 99 scan, if there are if the whole gland is involved, then you can't obviously do a hemithyroidectomy.
Hemithyroidectomy, yes, sir.
If the technetium 99M shows that the uptake in the rest of the gland is negligible and this nodule is taking up most of the radioisotope, then you are well justified in doing a hemithyroidectomy because you know once the suppression from this nodule is taken away and its suppression of the TSH, TRH and the thyroxine axis is lost, is restored rather, then the rest of the gland will start functioning normally. So you don't have to worry about the supplementation. So that is why radioisotope scan is critical in this patient.
Yes, sir.
Because if you in exams you can't justify that patient is not affordable or patient cannot come back
Yes.
for follow-up
Okay.
and all those things. Because if it is if the rest of the gland is normal functioning, she won't even require hormone supplementation.
Yes,
no.
sir.
Now even if she is total
Thyroidectomy.
thyroidectomy and you have put the patient on hormone replacement
Yes, sir.
for life.
Yes,
So
sir.
now you have to again follow up that patient every 6 months or 1 year with thyroid levels, whether you need to change the dose and all those things. Still, you
Yes.
have to do that follow up. So that can't be the answer.
Okay, sir.
So whatever sir said is the correct thing.
Yes.
Sir, any other thing, sir?
No, I think, tell me, you were there in surgery, no?
Yes, sir.
What are the things that you are worried about when you are operating on a patient with toxicity?
Like increased like bleeding, sir, like hemorrhage.
Okay, so what precautions do you take? What did Dr. Subhash do when you assisted him? Just remember that.
Yes.
Was there any bleeding?
No, not that much, sir.
Okay.
First,
So what?
we ligated the superior thyroid artery. Then, sir traced the nerve, and after that, inferior thyroid pedicle, sir, has ligated, sir.
Did he ligate the pedicle or did he ligate branches separately?
Pedicle, sir.
Inferior thyroid.
Pedicle, away from the
No,
gland
sir.
or close to the gland?
Sorry, actually, sir identified the nerve.
Hmm.
It's separated, and after that, he ligated the artery, sir.
As branches. See,
Yes.
No. Was it close to the gland or was it away from the gland?
Sir, close to the gland only, sir.
If it is close, you don't get the artery. It is the branches of the inferior thyroid.
Okay.
That is what sir is asking.
see, superior thyroid, comes at the apex.
Yes, sir.
And the superior laryngeal nerve will be there next to it. So you have to avoid that. When you come to inferior thyroid, the previous wisdom you used to be, if ligate the inferior thyroid away from the gland. That is when you get the pedicle. But
Yes, sir.
the current thinking is that you have to identify the nerve and then ligate the branches separately so that you don't damage the nerve.
Yes, sir.
Okay, so that is
Yes,
how
sir.
it is to be done now. So that is the main thing that you have to worry about, bleeding.
Yes, yes,
Because
sir.
though the patient currently is euthyroid, still the vascularity of the gland will be high. So you have to be careful.
So Indraja, you have done total thyroidectomy. What are the other complications
Yes,
apart
sir.
from bleeding which you expect? And when?
There may be injury to the nerve also, sir, but we have identified the nerve, and there will be chance of hypocalcemia in the post-operative period.
Did you identify
Why
the
will it be?
parathyroid?
Yes, sir.
Did you spare them?
Yes, sir.
Will they still develop hypocalcemia?
Sometimes there may be like transient ischemia, sir, to the parathyroids.
Not
In that
sometimes,
case-
man. Almost always. Because
Yes, sir.
where does parathyroids get their blood supply from?
Fr-
From the thyroid, superior and
Yes,
inferior
sir.
thyroid vessels only.
Yes, sir.
So, even though you have spared the gland, they will over a period of time develop blood supply, but initially transient hypocalcemia will be there in all patients who have had total thyroidectomy.
Yes.
So you have to watch for when does hypocalcemia, Niranjan asked you a question, when do you expect hypocalcemia to develop?
Sir, within 48 to 72 hours, sir.
48 to 72 hours early.
48 to 72 hours is.
Hello,
Sir?
sir.
Yeah, I think that is when you have to measure, but then you can expect it to go on for a period of at least, you have to check the calcium levels 1 week post-operatively also, even though the initial calcium levels may be normal, because that is when the full force of hypocalcemia will be evident. Or
Yes.
if the patient becomes symptomatic, what are the symptoms you expect?
Sir, tingling, perioral numbness, sir.
And then what do they develop? What happens? What is Schwarzschild-Weiss sign?
On tapping the zygomatic process, patient will develop twitching, sir, twitching of
Okay.
the.
Okay. And what else they can? What else will they develop?
Carpopedal spasm, sir.
So why does that happen?
So,
What is that called? Carpopedal spasm and the thing. Starts with T.
Trouser signs, sir.
No, it's not a name. What is that
Yes.
called? Is it not called tetany?
Yes, sir.
So,
Indraja,
So-
all these are like standard questions in a case of thyroid and hyperthyroid. You should not miss even a single answer in thyroid
sir.
and hernia, breast.
Yes, sir.
Okay, so you're still
Yeah.
struggling to answer tetany and all those things, then it is a bad thing. Okay,
Okay. Yes,
you have to
sir.
be very spontaneous. These are all already last class only we had discussed all this.
Yes, sir.
so you have to measure serum calcium levels at 48 hours or earlier if patient becomes symptomatic. Okay.
Yes, sir.
Or you have to repeat the levels at least at 1 week, because that is when the hypocalcemia will be fully set in. And how long do you expect hypocalcemia to last if it is temporary?
So 4 to 6 weeks, sir.
Yeah, usually 4 to 6 weeks.
Yes.
If it lasts beyond 3 months, then it is almost permanent
Permanent.
hypocalcemia.
Yeah.
I
Hello?
think
Hello, sir.
time
Yeah, I think 10, it is over.
10 o'clock.
Any other questions from anyone?
Students, any questions? Nikita, Praveen,
No, sir.
Praveen, are you there? He's on call. I don't know whether he's
He's
there.
on call, sir, today.
Abdul and Sania, anything you want to
Comments,
tell or
comments.
something?
No, sir, nothing.
Summarize. No, please summarize. Abdul, what do you think? How was our presentation?
Comments on how was her presentation? What was she lacking in, and what does she need to improve?
The presentation was good only, sir. Like all points were there.
Okay.
A bit more coherent in the way she speaks. Other than that, little fluency should be there, sir. That's all. Which
Okay.
will come with practice, right?
Okay. That is as far as presentation is concerned. What
Yes,
about answering the questions, defending her points?
that's what, sir. Some questions she didn't answer regarding that the medications. It should be on the fingertip. Like immediately, those questions are very common. In exams, especially, those answers should be on the tip of the tongue. So
Sania?
Yes, so
Sania,
the
what do you?
presentation was good, sir. Maybe history a little more detailed about the weight loss, that it was significant and how long, for what duration the weight loss was. And also about the investigation, sir, a little more detail about the investigation. Because I think we just discussed the iodine scan. Like, furthermore, what other investigations has to be done routinely for such cases? We have to tell that. Otherwise, it was good, sir.
Niranjan, I will just make some few
Yes,
comments
sir.
and
Yes,
then
sir.
give
Yes,
your
sir.
final comments.
Yes, sir.
Indraja,
Yes,
I think
sir.
all points in the history, as Abdul said, are there, history and clinical examination, but you should be able to be more, purposeful, more definitive, and, say it with conviction and confidence.
Yes, sir.
What is lacking in you is confidence in answering the questions and defending your, investigations or your treatment or whatever. You need to be more stronger to say why you are doing what you are doing.
Yes, sir.
Because you should be confident. I will do right hemithyroidectomy because this is a solitary nodule of the thyroid.
Yes, sir.
So so that you should be very clear, and you should know when to investigate, what to investigate, and what are the points that investigations are going to give you, which will aid in your management of the patient.
Yes,
See,
sir.
they will not, I think, as Niranjan has repeatedly told you, you cannot say patient cannot afford, patient is not coming for follow-up. All these things are not relevant. What you should give a perfect case scenario where the patient, you have to, say what you are going to do if everything is correct. So
Yes.
that is what they're expecting of you. So you have to read a bit more, and you should formulate your answers in such a way that you are able to defend them.
Yes.
Okay, Niranjan.
And I agree with all of the sir's points. In addition to that, you have to be answering very specific to the particular case which you are taken, not broadly. And also, you should not miss those points, like Nikita pointed out, that relevant history of pregnancy, and also drug history was inadequate. You didn't mention. You could have mentioned at least patient was not taking a beta blockers. Like
Okay, sir.
examiners will be like impressed that you have at least made an effort to find out. Since you have mentioned carbimazole,
Yes, sir.
immediately you should ask the patient whether patient was on propranolol.
Yes, sir.
Usually, invariably, a correct treatment would have been carbimazole and propranolol simultaneously. Nobody puts only carbimazole isolated.
Yes,
Okay,
sir.
examiner might think that you missed that, and
Okay.
that will be a significant history in a case of hyperthyroidism.
Okay,
Okay,
sir.
yeah,
Yes, sir.
okay, that's it.
Okay, sir.
Sir, we'll conclude.
Yeah, we'll conclude. Good night,
Yeah,
everybody.
yeah.
Thank you, sir. Thank you.
Thank you. Good night, everyone. Yeah.